I'm Joanne.
And I'm Janice.
We're a double act, the J's. And basically we just want to talk you through our journey through diabetes. It's obviously rising prevalence. I don't know how you find it in your units, but we are really, really busy. We have probably 10 new GDMs a week, so 40 a month. Last year our numbers were over 500, about 579. We do have type 1 and type 2 ladies as well, but it's the GDMs that are really increasing, which I'm sure you're finding in your units. Just a little bit of background, what is eggs about, why did eggs happen? How we used to run our service, we had a Thursday morning and we had a dietitian and myself and then my predecessor. I've been doing this job about 2 or 3 years, and we would book 2 ladies at 9, 2 at 10, 2 at 11 and 2 at 12, so we could see 8 ladies. I would spend half an hour with one lady talking through diabetes, teaching them how to monitor, and then they spend some time with the dietitian, and then we swapped over. So the ladies got good, it was one-on-one, but we were a bit bored because we were saying the same thing lots of times, and by the 8th lady I couldn't remember what I'd said, and the dietitian found the same. So we just found there was a lot of repetition, and then we found it was just rising. We use WHO guidelines, so it's a tighter control than NICE guidelines for our diagnostic for GDM. So we do have a really big caseload. And we just thought we were outstripping these clinics. We could see 8 ladies a week. There was about a 2-3 week wait. And Janice was a community midwife, and Alan, my colleague here as well. And they just saw in the community that they were having to really upskill, and because the ladies weren't getting to us in time. So we just thought we really need to change what we're doing. We really need to change it. So we just thought, let's do something different. Let's do a group. So I Googled it, tried to find a group, and I couldn't. I wanted to just see what that would look like to change, because change is different. It's not always welcome. I couldn't find anything. So we just kind of created what we thought might work. And then we came up with the name of eggs. So we started this, we just saw this rise in prevalence. We started this in April 2016. I can't believe it's nearly 2 years old now, eggs. And eggs stands for Educating Gestational Group Sessions. When we introduce it, we say to our ladies, it'd be great if there was a cooked breakfast this morning, but there isn't, although cooked breakfast is quite good for diabetes. But what is the point of it? The point is it's group sessions. Our aim is to empower women with information. So we get our GTT results 3 times a week from the lab. We look at the results and then we send out a letter. So when we were setting up the group, it was a lot of work with clinical staff, setting up the clinic. I spent time with the dietitians, and then we kind of formulated what is the eggs group today. So when we get the results, we send it out to the ladies. We give them what their parameters should be for normality. We give them their results. We explain it's a group, we explain we haven't got childcare. If they need a one-on-one for a translator, then we can organise that, which we sometimes need to do. But basically they know they're coming to about an hour and a half's group. And the format runs that we talk about diabetes with a PowerPoint. Some of these are taken from our PowerPoint. And then we hand over to the dietitian, but I'll explain more as I go along. So we want to empower the ladies. They go home with a bag, which I shall show you later on. We run telephone clinics. Ladies can access at any time. They have their own separate diabetes notes with our number on. But we do run every afternoon a phone clinic for about 10 ladies. So we book them in quite regularly, but they can call in at any time if they have any problems. We want to make them diabetic aware, offer peer support. We hope that within the groups they'll talk to each other. There may be different reasons why they've been diagnosed for GDM. As you know, there's different reasons, but they're all there for the same reason. So we want them to talk. Some ladies meet for coffee and support each other. We teach them how to do their blood glucose in smaller groups. We have a HCA involved that's really good as well. It's advice. We're making sure they've got onward scans for growth, serial 3 weekly scans. And it's really important we have time at the end to say to ladies, if you've got individual questions, then please do ask them at the end. Obviously, people don't always want to ask in a group. So that's what eggs is. So if we look at the impact here, can I just see if I can use this? Here, if we look here, this is how it's impacted. We wanted to see ladies in 7 to 10 days of diagnosis. So you can see it came down really poor here. And that's when just before here in about December, we were thinking we need to change what we're doing. This isn't good. Ladies shouldn't be waiting 3 weeks. I wouldn't. I try and treat people, I want to walk in their shoes, and I would not want to be told I've got GDM and not seen for 3 weeks. So what we did is, in March 2016, we started the eggs group and we saw to 78%, which was great from where we'd come to this 31%. We then had a bit of an problem with our lab, and we did really dip here in December. But then we came back up again, and then we hit 95%, and then we realised that we needed to work more. So from about June last year, we now do 2 eggs groups a week. So we usually have 6 ladies in each one, so it's in the 12 ladies. And as you can see, what we want is to see ladies within 10 days of diagnosis. So we're hitting that point there, and that is staying steady. So that was some research that we did, and that's our own audit that we did here. So that's our aim, to see ladies within those 10 days. What do the patients say? So I'll come back over here, I can see better. So we've surveyed ladies, and a lot of ladies, we've invited previous GDMs back to our groups as well. And a lot of the ladies just said they love the groups. I thought that they wouldn't want to monitor in front of each other, and in fact the ladies really like it, because what one's forgotten, the other one helps them. We tend to break them into smaller groups. And the things that I'm concerned about that ladies wouldn't like, they actually do like. So we've learned so much on this journey. We've developed on the journey, we've changed on the journey with our ladies. They have helped us form. The group that we started is now working with them has really helped. So their understanding of healthy eating, having a dietitian is crucial and fantastic. Understand how to use the meter, the session met their expectation, they feel confident, and you can just see all of those results are just showing that by doing groups, it's meeting ladies' expectations. That's just me doing a session. Janice and I share them. So it's great. The room that we use has got little tables, which is really good because they have a little bag, and they've got all their bits in the bag. We do a game, as you can see, the supermarket trolley. There's all sorts of like packets, and we go over, we give them out, and we talk about 5%, 5 grams or less sugar and fat, and they have a little game. So it's just a little game we play, supermarket sweep. They all have a bag, and in that bag is their monitor, a demo sheet of how to do their blood sugars, helpful hints. We use Diabetes UK material, and they take home. We called it a goodie bag, but a lady said, really, there's no chocolate in it. So we changed it for good for you bag. We don't have the goodie bag. We was really delighted. We were nominated, and last year we were awarded the Health East Enterprise for Innovation for starting our group, and we won that prize last year, so that's just us on the front of our magazine. And even our elves got involved, our elves on the shelf, and they had too much sugar, and I think their blood sugar was 27, so the elves got involved at Christmas. So that's a little bit about eggs. Please, we'd love to share more with you after. If you'd like to come and talk to us, come and visit. I know it's hard when you start on a journey, and if you want to change things, we've been there, so we're really happy to talk to you after and share more about our journey. I'm just going to hand on to Janice, and she's going to talk about colostrum harvesting, which we talk about in the eggs.
So I'm Janice. I joined the team in May last year. I became really interested. I was a community midwife, and what I saw was that women were waiting 3 weeks. I was excited to see that we had many type 1s coming through, but for me the disappointment was how many GDMs we had, and the prevalence was becoming more and more. So I thought, what can I do? And I applied for the job, got the job. But one of the things that I really noticed was the amount of women that were saying to me that, they'd had so many choices, they felt taken away from them because they were GDM. Now we're not going to deliver at home, we're going to deliver in hospital. We're going to need induction of labour because medically we know that we need to have these babies really delivered by term +6. So I was looking, and one of the things that really struck me was how many of these women wanted to breastfeed, but found that because, special care unit would say, oh, blood sugars are low, we need to take baby downstairs, what can we do about this? So I looked at colostrum harvesting, and it was something I wanted to bring to the team, and an interview spoke about. So as you can see there, there's a tube there, and the lady has harvested some colostrum in there. We know that colostrum going down the gut of a neonate will activate gut enzymes, which in turn helps with reflux, gets the baby ready to receive milk. The transfer of maternal immunities reduces the risk of allergens. But the real exciting thing for me, if we look at the national driver to keep babies out of NICU, and we also look at Attain to keep babies with their mums, what can we do? If we've got babies that the blood sugars are not dipping, they've got more chance of staying with their mums. So that was something that really interested me. I always tell ladies, this is not realistic. You won't get a tube of colostrum like this. But obviously, if I didn't do it like that, you wouldn't be able to see. And I will say to them, about this much, 0.2 mils, the size of my little fingernail, will keep a baby's blood sugars balanced. And they're amazed. And we did wonder, how will they take to this? Will they like it? How will they feel about it? I make it very clear, if you don't want to breastfeed, this is not what this is about. This is about a purpose with an end. So I talked to them about the fact that if they want to colostrum harvest, we can do this from about the week before they're going to deliver. We don't really advocate before 36 weeks, but obviously for some of our type 1s that we're saying, right, we're going to plan to deliver you at 34 weeks, let's give it a go. Even if you don't get any colostrum, learning how to handle your boobs, and I teach them with one of my nice knitted ones and my syringes here, and I show them how to do this. And what I point out to them is this is a baby that was delivered by section. Baby went onto the boob afterwards, but it's just a little tiny bit of colostrum which will hopefully keep this baby out of NICU. It's all been done. Baby's with mum, baby skin to skin, hat on, we're keeping baby warm. We're retaining that bond between mother and baby. There's some syringes. What we say to the ladies, if they do get colostrum, freeze it. You can use the same syringe for 24 hours. And all we do is we use it as a little tiny bit extra. It's not instead of anything else. The paediatricians are quite pleased because we've lowered the rates of NICU admissions, and we're also keeping these babies. You know, financially, it really, really works. But is this about finances? Every one of us in here will say it's not, because we're midwives and we're not going to talk about finances. It's about human cost. It's about keeping babies together. It's about getting babies home as soon as we can. And it's about empowering women that many of them feel that the choices have perhaps been taken away from them. So yeah, it's really about doing all of those things. So in the pack, they get a leaflet that tells them all how to colostrum harvest if they want to do it. We also fill in a form at our first meeting. When we see them in eggs, I talk to it, I introduce the concept, and for some of them, they'll say, I'm not sure, I need to know a bit more. So we put their name, contact details, their expected date of delivery, and then we speak to them. I also liaise with our infant nutrition team, and they support us with that so that we can get these ladies, if they want to, and they can come to us and we can teach them how to do it. Also speak to the community midwives. I'm very passionate about community. It's where you build your relationships. And I was a community midwife for a long time. So I work in partnership with the community midwives. They come in sometimes, ask me about, they come and get packs. So we try to make it a seamless service. Yes, you know, you have gestational diabetes or you're a type 1 or a type 2, but that doesn't mean to say that you can't do all of this and we can't keep your baby with you, because that's what it's all about, keeping mother and baby together. So, yeah, as I say, like inside the pack, we give out these packs. And when we looked at this, we had to put in a cost factor because these are going to cost money. And I just, in the way I do, just presented myself and said, well, it wouldn't matter how many thousands of these I'd have to produce. It would be thousands in a year if you want to use the cost of one admission to NICU, if I saved one admission to NICU. Because that is the reality, isn't it? How much does it cost for a baby to be in the neonatal unit with low blood sugars, because paediatricians are very nervous about leaving babies. Oh, no, mum's been a diabetic, we need to act. So we hope that it's giving women confidence, it's empowering women. It's also empowering community midwives and us to say, come on, we can do something about this, we can work with you. And what I found with the paediatricians, they've actually sat up and said, oh, you're doing something about it. You're not just going, oh, okay, the babies are coming to us. Well, yeah, we're going to do something about it, so work with us. So yeah, so that's what really colostrum harvesting is all about. So, has anyone got any questions for Jo? All right.
I think the thing we just want to say with eggs is that we use it for training as well. So Alan, one of our midwives, has been to eggs. We encourage staff, we get it on the doctors, the junior doctors that are coming, whether we've got GP rotation, and we just say, come to eggs, it's on twice a week. And people just begin, we want to empower our staff, we want to get champions within our unit in diabetes, because there's 2 of us. And we need to just, I'm sure you've got the same, you just need to make sure everyone's empowered. So we use it as a teaching tool. We have student midwives, student nurses, and they come along to eggs, and they can use that for revalidation. So we use it as obviously it's for the ladies, but we use it as a training tool as well. Yeah.
I wanted to clarify, you said you keep the syringe for 24 hours. Do you mean from when they start to use it or when they start to give it?
So what happens is the ladies are given a pack initially of 5 and they can use the same syringe for up to a 24-hour period and put that colostrum into the syringe. Put a bung on it, there's all labels, and they have a tub, and then it's put into the freezer, and the next day, because we're only encouraging about 4 times a day initially, no more than about 10 minutes, just to stimulate, to sort of activate, the production of colostrum. Women produce colostrum from about 20 weeks. So, and in this world where seeing is believing, as much as you can say to women, yes, you've got a plentiful supply of milk, yes, you'll be absolutely fine. This world is all very much about it's what you see is what you get, isn't it? So they actually see some colostrum in the syringes and that empowers them again. And it doesn't matter what I say about, of course you've got colostrum, they want to see it, don't they? So yeah, it's got that added benefit as well.
What about women that don't have GDM but are still interested in harvesting colostrum? Could you still argue the point that you did earlier about
And I have done repeatedly. What we found is because we've got Maternity Direct Plus, it's a service at Basildon Hospital, you can go on to the internet, you can actually make contact with a midwife 24 hours a day.
Right.
And word gets about, the drums were beating, these babies weren't going to NICU, I want to colostrum harvest, I'm not a type 1 or I'm not a gestational diabetic.
Yeah.
So we said, of course. I mean, we wanted to roll it out, see how we got on. And we have to look at capacity and cost. We don't want to, but we have to. Mm-hmm. So I went to the infant nutrition team and I said, oh dear. And she's, no, it's fine. So any lady that, sort of makes contact and wants a kit, we do that as well.
You do.
I'm part of that, and so the infant nutrition specialists,
And so, because I spoke to my line manager about this recently, because it is something that I feel quite strongly about also.
Yeah.
And then she did bring up the cost. And what about if I recommended that the women bought them themselves? Is that an option, or do you think that's probably not advisable?
It is something that can happen, but maybe what you perhaps need to do is you can, take our names afterwards, and I could put you in touch with the infant nutrition team that I work with, because these syringes were actually patented because we needed them for a certain, because it sounds really silly, but in a syringe, if you only get 0.1 mils of colostrum, you'll lose it in the actual little tiny bit of the end of the syringe, and you can't get it out.
Yeah.
So we needed a flat syringe, and I make it very clear to ladies it's a needleless syringe.
Yeah,
because when you say that,
they go, oh no, what are you doing to me? So so it might be an idea if you are really interested to contact them, and they may be able to help you with the supplier, because that was something that took us a long while, and in the end we were talking about trying to design one ourselves, because these come from China, don't they? We import them from China, but they've been very cost effective and it is working.
I think the only other cost I was thinking is that we invested in a freezer in the postnatal ward and a warmer, so that we can put the colostrum in frozen and it warms it, so they can have it straight away. Just this tiny device so that the syringe goes.
Yeah, but I mean, there's nothing to stop women using normal syringes, but you would need to explain to them, you would get tiny amounts, and the last thing you want is to have a tiny little bit of colostrum and you can't get it here, because that would be awful, wouldn't it? So that's why we use those ones.
Sorry. I just wondered, what is the correlation between raised BMI and GDM? Do you have any statistics on that off the top of your head?
I haven't got off the top of my head, but I could say that a lot of ladies, it's one of our 7 criteria, and I would say it's one of the biggest reasons. I would say it is, when I think of a group, if I was to think of, say, a group in a week, I would say realistically about, say, 10 GDMs with new GDMs, probably at least 50%, if not more, are BMI.
Yeah.
And when raised BMI, are we talking over 25 or
over 30? We monitor for over 30.
We do as well, okay.
Yeah. But part of our session is we talk to ladies about their onward journey, and that, within 5 years, if we don't change our lifestyle, we're likely to be type 2. So they then have an opportunity to change their life going forward as well, and lowering their BMIs. And so because we've got BMI clinic as well that runs at Basildon, so we sort of work hand in hand. can.
ourselves in
Yeah.
part of a
Partnership,
chain.
yeah.
And I guess that comes as part of that education, then prevents obesity and diabetes in children. If you're
We talk all about that as we
yeah,
talk, kind of,
okay.
we do the format, and then we talk about, you know, actually what we're doing now is for your onward journey, for you and your unborn baby, and we talk about,
Yeah.
so we just hope that we're spreading that healthy message to prevent them getting type 2
Yeah.
and the babies.
Thank you so much.
Do you, quite a lot of your ladies with GDM, do you manage to keep quite a lot of them diet controlled? So when, obviously every trust works differently, do you hand your ladies back over to the community midwives when they're diet controlled beyond a certain gestation? So we tend to take our ladies back in the community if they've not needed anything.
Yeah, we've got a good pathway. It's like the general ownership of diabetes we set up in about 2014. So very often we have initial contact in eggs, and then a lot of our contact, because the ladies surveyed said that they'd prefer it is telephone contact. So we don't actually physically see a lot of the ladies. A lot of it would be done by the community midwife. Obviously, our next step from diet is metformin, and then we would need to see them more often, and then if they're on insulin. But it's definitely we share the care with our community midwives, because we want everyone looking at their book, from consultants to MCAs to the midwives, so that they're looking at their blood sugars, because if not, we just felt we can't do it all. 500 women a year is too many. So if we had our own clinic and we kept it all to ourselves, we're not sharing it. So the good pathway, general ownership, is people who, so we say to the ladies when we meet them in eggs, whoever you see, they need to be looking at your sugars. And the community, it's great when you see community midwives documenting blood sugars within normal range, or blood sugars are high and ringing us, because they're looking at the books. So yeah, we do share it.
Hi, I think it's really interesting what you're doing with the colostrum harvesting. I was just wondering if you've had the opportunity to audit whether it's improving exclusive breastfeeding rates at all.
What we started, as I say, I joined the team in May and sort of rolled it out really as a little bit of a tester. So what we decided to do was, from the beginning of this year, in partnership with the infant nutrition team, we've now started to audit, because we rolled it out and then we were trying to play catch up with fridges, with warmers, and trying to sort of twist the arm of our head of midwifery for the money for all of that. So initially, when we started it, to keep the stats was difficult, but we do know that 100% of our women are offered the opportunity to colostrum harvest, and about 70% of them are actually taking that opportunity up and turning up with colostrum, to a point where they were saying, we might have to buy another freezer. And what I found really encouraging was there were some women who said, I've never thought of breastfeeding, but I will colostrum harvest. And our hope is that with these statistics, what we'll find is those women have perhaps gone on to breastfeed if they want to. Of course, this is all about choice. This is all about, giving them the information, giving them the tools, and if you'd like to do it, do it. And if you don't, that's absolutely fine. It's there if you want to take it. So, yeah. So watch this space. I might have statistics soon.
Questions? I thought there was a lady in the middle as well, but I wasn't sure. No? Okay. Thank you, Joanne and Anne, for a brilliant presentation.
Thank you.